So now that we have covered the acute physiological response to a muscle injury, particularly a muscle strain, we are now delving into the acute/immediate treatment of the injury and the subsequent rehabilitation of the muscle, and thereby MTU, back to pre-injury status. In this lecture series, you will have a greater perspective of why it is so important to understand the mechanisms post-injury leading up to the full repair of the muscle. This is because many of the evidence-based acute treatment modalities as well as rehabilitation modalities target some area of the post-injury mechanisms that we discussed in the prior lecture. For example, during the destruction phase, acute treatment strategies may target excessive inflammation or hematoma to minimize that wound gap, to help facilitate quality healing through a greater regeneration to fibrogenesis ratio. We talked about the mechanism underlying pain or nociception post-injury and how that mechanism is a target of intervention during acute treatment and rehabilitation phases. In this lecture, we will talk about how those mechanisms of pain are manipulated through various anti-pain modalities, otherwise known as analgesics. And of course, as I hinted at multiple times during the last lecture series, we will discuss some of the controversies with certain analgesics, which may mitigate pain but also at the same time impair regeneration processes. I'm alluding to the use of NSAIDs. More on that later. Now, as you can tell by the title slide, this will be a two-part series. Part 1 will mainly focus on strain diagnosis, fundamental aspects of acute treatment and rehab modalities, and acute treatments, which generally refers to the most immediate care to the injured muscle. Part 2 will cover everything thereafter leading to full rehabilitation and return to sports status. We will also discuss some prehab modalities as well. So just to provide an outline for this two-part series, first we will have a mini review of the last lecture series with a fill-in-the-blank exercise. Particularly, we will briefly review key points related to the causes of a muscle strain and the mechanisms leading up to the repair and remodeling of the muscle. Remember, having a solid understanding of these mechanisms presented in the last lecture will be very important to have before delving into the topics presented in the series. After this little review, I will go over the different classifications of a muscle strain based on its severity, and of course the diagnostic markers for each of those classifications. In other words, what constitutes a grade 1 strain versus a grade 2 strain based on diagnostic imaging, for example. Next, I will discuss the major predisposing factors of muscle strains. So this discussion here will relate to the different risk factors, particularly the non-modifiable ones. For example, I will discuss what types of muscles are most susceptible to muscle strains, and what characteristics of those muscles make those muscles more predisposed to a strain. Next, we will dive into the fundamental aspects underlying all acute treatment and rehabilitation interventions, meaning what is the foundation for any effective treatment and rehabilitation strategies. So with that, we will talk about the concept of early and late functional recovery and how these two concepts are interrelated and how they influence the quality of healing and rate of rehabilitation back to return to sports status for an athlete. Then from there, we will have the major topic of part 1, which is acute treatments for muscle strains and the mechanisms underlying those treatments. In other words, our goal here is to understand the fundamental reason as to why we treat a muscle strain the way we do in the acute immediate phase. Here we will discuss why we ice, why we compress, and why we elevate, for example, immediately following the injury. And I will introduce some new acute treatment concepts that have been introduced recently in the scientific literature, such as the concept of optimal loading in the early phase post-injury. Now, much of the fundamental concepts regarding acute treatment modalities were briefly introduced in the previous lecture series, where I discussed how acute treatment is mainly predicated on reducing edema and excessive inflammation to minimize the wound gap, in addition to careful pain management, as I will introduce and discuss later. A large section will concern the reason why pain management is important to facilitate regeneration and remodeling, but also why it must be carefully implemented to prevent any mitigation to regeneration. Going along with that, I will go over the science of acute pain management and describe the mechanisms through which various acute pain management strategies like cryotherapy, manual therapies like massage, transcutaneous electrical nerve stimulation, or TENS for short, and anti-inflammatory drugs. Here we will describe some classic neural mechanisms related to acute pain management, such as the gate control theory. And this will transition into the discussion of the anti-inflammatory paradox, which describes the good and the bad of targeting the acute inflammation that occurs following a strain as a means to manage pain, and why it can be good and at the same time it can be bad. So this clearly hints at why I refer to the use of anti-inflammatory drugs as paradoxical. And in part 2, as I said, we will go over the topics that relate to rehabilitation and the key components of quality rehab. And this is usually during the remodeling phase, so many of the evidence-based practices in terms of rehabilitation is centered on targeting and thus facilitating the remodeling of the muscle architecture to restore its full function/strength. And as much as we will discuss rehab, we will also go into prehab or strain prevention strategies. And this largely has to do with exercise-based prehab methods. Here we will discuss the use of eccentric overload training as a means to make the MTU more resilient to eccentric overloading situations in sport, which we said are the most conducive to a muscle strain. Then finally, I will apply some of these concepts in an EIMD and day-to-day recovery situation, which is obviously pertinent to the general athlete both in season and off season. All right, as I said, let's go ahead and do a brief review of the different phases following a muscle strain as discussed in our prior lecture series. Again, this will be through a fill-in-the-blank exercise and for the purpose of refreshing your memory on key mechanisms to help you comprehend new information in this lecture series that relate to those mechanisms discussed in the prior lecture. Now, before we get into this review, I want you to pause this video and try to fill in those blanks as to the best of your ability. This is not a quiz, but just a simple exercise to check your level of comprehension thus far. So why don't you go ahead and pause now and begin the exercise. Okay, hopefully you were able to fill in most of the blanks and you felt confident in your understanding of the prior material. Let's go ahead and go through each of these bullets together. First, we will have the destruction phase, which we know by now is the most initial immediate response to the strain and rupture of muscle fibers, as well as the myofascia/ECM, the motor neurons, and also the micro blood vessels. Here we obviously focus mostly on muscle fibers and the processes within. All right, so necrosis of damaged muscle fibers is due to influx and leakage of calcium, stimulating calcium-activated proteases, which are enzymes that catalyze protein degradation or proteolysis, in other words. Second, there is an initial passive infiltration or leakage of inflammatory cells that release proteases and free radicals, which also help break down damaged muscle fiber segments. Next, contraction bands, or plasma-lemma membranes, protect undamaged portions of muscle fibers from necrosis, creating the surviving zone. The wound gap between fiber stumps, which are the ends of the surviving zone, and the regeneration zone is filled with a hematoma, eventually forming a blood clot. And as I said, this is largely mediated by clotting factors from blood platelets, such as chemicals like thromboxanes. Swelling or edema occurs due to ruptured vessels and collection of intracellular and extracellular fluids, mainly water. And this is mediated through the pressure gradient changes caused by the ruptured blood vessels, driving blood from high to low pressure towards the rupture site. Inflammatory cells such as neutrophils, which are the first responders, and M1 macrophages are recruited through specialized cytokines called chemokines, which are also referred to as chemoattractants. Inflammatory cells not only further necrotize damaged fibers, but also, quote-unquote, clean up necrotic debris through a process called phagocytosis. Inflammatory cells and damaged cells themselves release an assortment of cytokines, growth factors, and prostaglandins, which we didn't discuss in much detail but will in this lecture, to regulate the inflammation and initiate the healing process. And just as a side note, which two growth factors did we introduce? Insulin-like growth factor 1, which is highly implicated in healing through regeneration, and TGF-beta, which is implicated in healing through fibrogenesis, scar tissue formation. To protect the damaged muscle tissue/cells from further mechanical stress, acute inflammation is associated with nociception, which is a sensory process associated with the perception of pain. Remember, during inflammation, chemicals released by inflammatory cells, as well as from damaged muscle fibers, can become noxious stimuli when in high amounts. Thus, the noxious stimuli associated with the acute inflammation is chemical noxious stimuli. This will stimulate nociceptors, which will carry that quote-unquote threat signal to the CNS, and if these signals are considered a credible threat, then the CNS will create the sensation of pain. And as I said, these chemical noxious stimuli will also decrease the threshold of mechanical receptors on nociceptors, making them much more sensitive to any kind of mechanical stimuli, such as contraction or stretch of the muscle. This is why it hurts when you try to use a sore muscle. And going along with that, nociceptors depolarize, or essentially are activated, to noxious stimuli, which include thermo, mechanical, and chemical stimuli. Now, I need you to remember this moving forward in this lecture when we discuss pain and pain management in much more detail. Now, next two we will skip over, but just understand that the chemical noxious stimuli are derived from both the damaged fibers as well as the inflammatory cells. And I provided a list of those chemical noxious stimuli in the prior lecture series. Now, lastly, on the destruction phase, some of these chemical noxious stimuli are also chemicals that initiate and regulate repair, more specifically healing, and even more specifically regenerative healing, or simply regeneration. So keep that in mind. That's a very important piece of information moving forward in this current lecture series. All right, moving on to the repair phase. Healing involves two concomitant, supportive, and competitive processes: regeneration and fibrogenesis/scar tissue formation. Regeneration is both functional and structural, and fibrogenesis/scar tissue formation is just structural healing. Now keep in mind, the structural healing part for regeneration is much different than the structural healing with scar tissue formation. If you are unfamiliar with this, please revert back to the prior lecture series on this topic. M1 macrophages release growth factors such as IGF-1 to initiate regeneration via muscle progenitor cells, such as satellite cells, muscle-derived stem cells, and mesenchymal stem cells. Also keep in mind, IGF-1 is not the only player, as other chemicals/cytokines released by inflammatory cells also play a role in initiating regeneration. For the sake of simplicity, I only focused on IGF-1, but just know that there are chemicals/cytokines released by these inflammatory cells that also play a role in initiating the regenerative process. Macrophages undergo M2A polarization, which inhibits M1 macrophages, which start to initiate the anti-inflammatory phase. M2A macrophages also release growth factors such as IGF-1 to stimulate regeneration in the muscle tissue, and TGF-beta, transforming growth factor beta, to stimulate fibrogenesis, particularly scar tissue formation. You also have to understand that fibrogenesis is also the process leading to the reconstruction of the ECM material as well, so any collagen-based tissues. Focusing on satellite cells, once activated, they initially proliferate, then differentiate into myoblasts, which are cells committed to the myogenic program. They are committed to becoming part of the muscle fiber. Now, continuing on with the repair phase, during regeneration, scar tissue also continues to form in the central zone at a generally fast rate. Remember, the rate of fibrogenesis/scar tissue formation exceeds the rate of regeneration. And this is purposeful because we need that scar tissue to keep the muscle fibers somewhat intact so that regeneration can proceed efficiently. Scar tissue only becomes a real issue when there is fibrosis, when there is just too much, preventing the muscle fibers that were damaged to fully interlace and reconnect. Myoblasts eventually fuse to form myotubes and fill in the regeneration zone using the existing basal lamina as scaffolds. About 5 days post-injury, depending on severity, M2A and M2C macrophages promote anti-inflammation by inhibiting M1 macrophages and the release of pro-inflammatory chemicals like cytokines, prostaglandins, and free radicals, which I said earlier not only play a role in regulating inflammation and the initiation of regeneration, but also serve as noxious stimuli to involve pain to protect the muscle while it is in the process of repair. So M2A and M2C macrophages promote anti-inflammation by inhibiting those M1 macrophages and their release of pro-inflammatory chemicals. Regenerating fiber stumps on each side of the central zone pierce through the scar tissue. After some time, the ends of the fiber stumps adhere to the scar tissue through synthesis of adhesion complexes, aka costomeres, especially integrins, which I didn't talk about much, but yes, integrins are the common costomere that adheres the fiber stumps to the scar tissue. And of course, this would form new intermediary mini MTJs within that muscle fiber. So that muscle fiber is essentially split, and it's split by scar tissue. Muscle function is restored not only when fibers regenerate, but also reinnervation of motor neurons occur. Describe the difference in collagen matrix between scar tissue and normal ECM/fascia. Scar tissue collagen is stiff and dense, and the matrix is disorganized, while ECM is made up of a mixture of dense and fine collagen fibers that are relatively organized into a mesh-like structure. This is particularly the case for the endomysium. And finally, we have the last phase, the remodeling phase, where the muscle tissue has undergone significant amount of reconstruction. So first, to summarize the remodeling phase, typically by this phase, the athlete is engaged in rehabilitation and strength training and is soon able to return to play since most function is restored and not limited by acute pain. During this phase, regeneration in the regeneration zone continues, and the central zone reduces in size due to the biological removal of scarred tissue. The scar tissue, in other words, is condensed by the regenerating and thus growing fiber stumps. The fiber stumps on each end of the central zone grow closer together and make attempts to interlace, although total eradication of scar tissue is unlikely. This is especially the case with higher grade strains and the presence of fibrosis. All right, so there you have it. Hopefully by now you have a solid understanding of the post-injury mechanisms leading up to full repair and remodeling of the muscle, where it is now fully functioning back to pre-injury status. So with this information now, we can identify the targets for acute treatment, pain management, and rehabilitation/recovery. So many of the mechanisms as just reviewed will be reintroduced as we discuss the road to recovery. And also, you must always keep in mind as we continue into this lecture series that all the acute treatment and rehab modalities are fundamentally intended to facilitate quality healing, which I emphasized previously is defined as greater regeneration to scar tissue formation ratio. We want to achieve both functional and structural healing mainly through regeneration. So we want to implement interventions to support the rate of regeneration so that there is a better chance to minimize fibrosis and to interlace those fiber stumps together. All right, so now let's get into the diagnosis of muscle strains by first identifying the three traditional grades of strain severity. Now, I want to reiterate that muscle strains occur when there is excessive tension on the muscle. We should know this by now. This mostly occurs as a result of a maximum effort contraction against a more forceful external pulling force. I am describing a maximum eccentric contraction. The area most susceptible to the strain is the point in between the direction of the contractile force and the direction of the external counterforce. A less common way a muscle strain occurs is when the muscle experiences excessive tension through overstretching, which does not involve a contraction force, but rather an external pulling force only. For example, imagine a football player while getting tackled had their entire leg pushed back, suddenly stretching their hamstrings to the point of a strain. This again is not the most common way a strain occurs, at least in sports. Most strains occur during sudden, high momentum acceleration and deceleration situations, where there is a very rapid rate of tension development through a rapid application of an external counterforce coupled with a rapid maximum effort contraction. This was explained in detail in the last lecture when I discussed the GTO mechanism using the long jumper example. Okay, so let's say a muscle strain was experienced by the athlete during a sudden deceleration moment, like landing on one foot after jumping really high. After the injury, we have to now diagnose the severity of the strain to understand the prognosis through treatment and rehab. One fact you should be aware of is that in most cases, there are no objective diagnostics for a muscle strain, meaning the grade of muscle strain is usually determined through subjective measures, which include perception-based feedback from the athlete, observation of movement and strength, ability to tolerate load or mechanical stress, and in most severe situations, evaluation of images, usually derived from MRI or ultrasound. Imaging the MTU that is injured is usually implemented when there is complete immobilization and severe pain, meaning the athlete can't move the limb associated with the injury. And this is mainly to verify what type of injury it is, whether it is a tendon strain, a muscle strain, or a ligament sprain. Secondly, the imaging can obviously be useful to identify the severity of the muscle strain if it is indeed a muscle strain. Now in the next slide, I will share some diagnostic images so you can have a better visual of all this. So with that being said, here are the general and mostly subjective criteria for each muscle strain grade. A grade 1 strain, also referred to as a mild strain, is a step above EIMD and involves a rupture of a relatively small number of muscle fibers. Usually with grade 1 strains, there is not a large wound gap in the muscle tissue and minimal hematoma and swelling. Immediate sharp pain upon the tear is relatively small but noticeable, and usually within 24 to 48 hours, the injury will present itself with soreness. And based on our last lecture, you should understand this is largely due to the acute inflammatory response. This can also be considered a form of delayed onset muscle soreness, or DOMS, similar to that experience following a heavy workout. With grade 1 strains, there's minor reductions in strength and range of motion. In other words, there's minor reductions in muscle function, since there is minimal ultrastructural damage, motor neuron denervation, and pain. These are the three factors that are the limiters of muscle function post-injury. With grade 1 strains, as you must have already guessed by now, does not involve an excessive inflammatory response, which contributes to the low level of pain. Nevertheless, acute treatment strategies to minimize the chance for excessive inflammation should be implemented and of course will be discussed shortly. Next, we have a grade 2 strain, or a moderate strain. Grade 2 strains involve a large number of ruptured fibers in addition to micro blood vessels causing significant swelling due to the accumulation of intra and extracellular fluids, as well as hematoma, bleeding. Some denervation can also occur with grade 2 strains, but not much. So because of the larger rupture, there is a greater acute inflammatory response, which is oftentimes excessive and thus requires immediate intervention through some type of anti-inflammatory modality. At the moment of the strain, there is immediate sharp pain due to the tearing of the tissue, and the soreness thereafter that is associated with inflammation is not as delayed as a grade 1 strain. Usually this occurs on the same day. This, of course, contributes to increased tenderness when tension is applied to the injured muscle, even if it's minimal. Why? Again, because the inflammation and the chemical noxious stimuli not only causes soreness through the chemoreceptors on these nociceptors, but increases the sensitivity of the mechanical receptors to mechanical stimuli, such as tension. Thus, even with tension that normally does not induce pain, will now induce pain. And this is all for the fundamental sake of protection. Now, as you can imagine, there will be marked reductions in strength, and when quantified either objectively or subjectively, there is about a 5 to 50% impairment in function. This, as I said, is largely assessed subjectively. And finally, we have the grade 3 strain, which is often referred to as a complete tear to the muscle, and almost every time the tear occurs right around or directly on the MTJ. This is why grade 3 strains are usually accompanied by a tendon strain as well. Think of this as a complete rupture of the MTU at the MTJ site, and thus a complete disconnection of the muscle to the tendon. This type of complete tear to the MTU is referred to as an avulsion. Again, keep in mind tendons run to different lengths of the muscle, so these avulsions can occur even closer to the belly of the muscle since MTJs can be located there. So this goes without saying that grade 3 strains accompany a complete loss of function of the torn muscle. Keep in mind, however, there could be some function for a particular joint action if the joint is associated with multiple muscles. An example is the quadriceps. You can, for example, have a grade 3 strain on the rectus femoris and lose complete function of that particular muscle. But you may be able to still extend your knee and have some function in that joint action because you have other non-injured quadricep muscles like the vastus lateralis, medialis, and intermedius muscles. So with that said, if there is a loss of 50% strength/function, say in knee extension, according to this example, there is a likelihood that an avulsion has occurred. Fundamentally speaking, the complete loss of function in the torn muscle/MTU is due to the fact that the muscle is completely disconnected from the tendon. So even if the muscle is able to contract, there is no longitudinal force transmission and thus transfer from the muscle to the tendon and therefore the bone to allow for joint actions to occur. Also, you can imagine that a lot of scar tissue needs to form quickly to reconnect the severed ends of the MTU. This will be an important topic that we will discuss later on in this lecture series. Also, what is contributing to the total loss of function of the torn muscle beyond the ultrastructural damage and the disconnection between the muscle and the tendon is motor unit denervation through severed nerve fibers and destroyed neuromuscular junctions, as described in the prior lecture. And of course, the most obvious limiter to muscle function would be the severe pain. During an avulsion, there is immediate sharp pain directly due to the severe tearing of the tissue. Also, the ensuing soreness due to inflammation occurs relatively quickly as well, since the acute inflammatory response in this case will be rapid and severe. And of course, with grade 3 strains, the acute inflammation is typically excessive, and thus acute treatments must be applied immediately to reduce the excessive inflammation. Now, as a reminder, no matter what you do, however, you cannot totally prevent inflammation. That would be impossible and counterproductive to normal biological processes following an injury, since inflammation is necessary to lead into the repair processes. You are just only trying to control and limit excessive inflammation, and I will reiterate why in a few moments during this lecture. Also, a grade 3 strain involves severe hematoma and thus swelling. Again, not only due to the hematoma, but also the accumulation of intra and extracellular fluids like water. As mentioned in the prior lecture, acute treatments should also mitigate swelling to minimize the wound gap as much as possible. This will also be reiterated shortly when we get into acute treatment modalities. As I briefly introduced earlier, a grade 3 strain, more so the immediate symptoms of a grade 3 strain, usually calls for diagnostic imaging to confirm the avulsion, as well as to verify the location and severity of the avulsion, and to assess whether other soft tissue structures have been injured, such as the tendon and ligaments. Now, you may be wondering, how do you know whether it was a muscle strain versus a ligament sprain, which are both tearing injuries? Of course, this can be confirmed using diagnostic imaging, but any acute care professional like an athletic trainer can assess the type of injury through the movement that caused the injury. For example, as indicated earlier, muscle strains usually occur during a rapid maximum eccentric contraction, typically in the form of a rapid acceleration or deceleration moment. Muscle strains usually occur without any contact from other players or external objects. The external force and the opposing contractile force leading up to the strain are all applied by the athlete him or herself. Now, during a ligament sprain, there is usually an unnatural joint action. For example, with knee ligaments, a tear would occur when the knee joint is twisted excessively, which is unnatural for the knee, since it is primarily an extension-flexion joint. Another example is a knee or elbow hyperextension, where the joint is forced beyond its normal range of motion, usually by contact with an external object. So it is not that difficult to assess whether there was a muscle strain or ligament sprain immediately following the injury. But diagnostic imaging, especially for grade 3 strains, can be implemented to confirm that no other soft tissues have been severely damaged. And yes, there are situations in which a muscle strain and ligament sprain can occur simultaneously in sports, which is a very unfortunate situation. This usually involves the limb coming into contact with an external object, forcing it beyond the range of motion of the associated joint. In this case, the muscle strain occurs because it is overstretched, not because of a max eccentric contraction. Again, this is not a very common way a muscle strain occurs. All right, let's take a look at some diagnostic MRI images of the hamstrings for each grade of strain. Now, in these images, we have a strain to the biceps femoris, which is made up of a long head and the short head. What is highlighted with my cursor here is the long head. Now, as a refresher to your movement anatomy course, the long head of the biceps femoris muscle originates on the posterior part of the ischium tuberosity, which is the bottom curved portion of the pelvis. So one tendon attaches the biceps femoris there across the hip joint, and the other attaches on the lateral aspect of the knee at the head of the fibula, which is the outer smaller bone of the lower leg, and the lateral condyle of the tibia to some extent, which is the large bone of the lower leg. So on this end, the tendon attaches the muscle across the knee. So the biceps femoris crosses two joints, the hip and the knee. This will be a very important fact in the upcoming slides. All right, so let's look at the first image to the left. This is a representation of a biceps femoris that has undergone a mild strain or a grade 1 strain. In diagnostic imaging using MRI or ultrasound, hyper-intense areas that show up brighter are areas in which fluid is accumulated. So these hyper-intense areas, as you see here, are markers for edema. And part of that edema is hematoma. So if these hyper-intense areas are relatively large, then that indicates larger edema and thus a greater degree of rupture. Remember, the edema is swelling due to hematomas and fluid accumulation when the muscle tissue is ruptured. In that it goes along this edge right here. So in this image, you can see that the pattern of the edema is very unique in that it goes along this edge here, almost halfway down the muscle. What do you think this edge is? This edge here is the MTJ, since the proximal tendon that attaches to the ischial tuberosity runs down the edge of the biceps femoris, almost 60% of the length of the biceps femoris. If you skip to the next slide real quickly, you can see a cleaner textbook image of that. So all this edema is essentially located all along the proximal or upper MTJ of the biceps femoris. This means that the ruptures to the muscle fibers occurred on the muscle around the MTJ. To reiterate, the MTJ, again, is the area that experiences the most tension during a maximum eccentric contraction. Now, in the grade 2 strain image, you can see much of the same thing, but with greater hyper-intense spots, which again would indicate greater edema and thus greater ruptures. You can see the ruptures along the proximal MTJ, and you can also see ruptures that occur on the distal MTJ, the MTJ that connects the distal part of the muscle to the distal tendon that attaches to the lateral aspect of the knee. And in the grade 3 strain, as you see here above, there is a clear sign of severe edema and fluids have accumulated largely in this one area. If you look closely, you can see that the MTU is severed. In this case, it is severed at the proper MTJ on the proximal end of the muscle. So the biceps femoris is completely severed from the tendon. And as I emphasized before, this would obviously result in a complete loss of function of the biceps femoris, meaning the biceps femoris will be unable to contribute to the joint actions it is associated with, such as knee flexion and hip extension. However, again, keep in mind, these joint actions are still possible because you have other hamstring muscles that are uninjured. Also, to reiterate, contributing to the loss of function in the biceps femoris in a grade 3 strain would also be severe motor neuron denervation as well as severe pain, which would obviously avert you from using your hamstrings. Now, as a side note, as indicated below here, diagnostic imaging is rarely, if ever, required for a grade 1 or 2 strain. And sometimes it's not even required for a grade 3 strain as long as there is no suspicion that other soft tissues have been damaged. If imaging is necessary for strains, ultrasound is utilized as a more practical approach than an MRI. And an MRI, as shown in these figures here, is mostly utilized to examine detailed characteristics of a lesion, which is another term for an area of tissue damage. So what types of muscles are most predisposed to a strain? One major characteristic of a muscle that has a high strain susceptibility are those that cross two joints. Let's take the biceps femoris for example, as pictured here. As I mentioned earlier when I was examining the MRI images, the biceps femoris attaches across the hip as well as the knee. What this means is that an external counterforce can be applied to either end of the biceps femoris independently or at the same time. An external counterforce can pull on the biceps femoris by acting on the hip joint or by acting on the knee joint. This is in contrast to muscles like the deltoids that only cross one joint. As you may know, the deltoid is not very susceptible to a strain, and this characteristic is one of the reasons. Now, other muscles that share this characteristic and are known to be at a high risk for strain include the rectus femoris, which is a large quadriceps muscle, and the medial head of the gastrocnemius, which is part of the larger calf muscle. Now, other characteristics that increase strain risk include a large type 2 fiber type distribution and a pennant architecture. These three muscles also share these characteristics. First, the reason as to why a large type 2 fiber type distribution contributes to the strain susceptibility of a given muscle is because type 2 fibers generally have a greater rate of tension development during contractions versus its type 1 counterpart. As you may imagine, a greater rate of tension development coupled with an external counterforce would result in a very rapid increase in tension development in the muscle, which, as we know, is a situation conducive to a strain. Next, as you can see in this textbook image of the biceps femoris, the muscle has a pennant shape where the fibers run in an angular direction from one tendon to the other. The rectus femoris of the quadriceps muscles is similar to the biceps femoris, but it has a bipennant shape in that the tendon runs down the middle of the muscle and the fibers project at an angle from the tendon. On the next slide, you can find a clearer image of this. One of the reasons why a pennant-shaped muscle is more predisposed to a strain is primarily due to the fact that these types of muscles have large tendons and thus a large MTJ area. If you examine the biceps femoris long head tendons and MTJ area, you can see that the proximal tendon runs the majority of the length of the biceps femoris. In fact, it extends about 60% of the muscle length. This means on the proximal end, there is a very large MTJ area. In addition to this, the distal tendon runs almost 66% of the length of the biceps femoris, which altogether means that there is a very large MTJ area within the biceps femoris, meaning a strain can occur almost anywhere in this particular muscle. In the MRI images of the grade 1 and 2 strain in the prior slide, you can see the ruptures occurring all along the edge of these tendons, indicating that those ruptures are occurring around the MTJ. Now here on the right is an MRI image of the rectus femoris after a strain, which I mentioned has a large proximal tendon that runs down the middle of the muscle, almost to the belly of the muscle. And in this image, you can see the hyperintense areas that indicate edema and thus ruptures. And when you examine the edema pattern, you can clearly see where the MTJ and thus tendon is located, highlighted by my cursor. It is right down the middle. You could also see in this image that the biceps femoris has a bipennant shape, as I mentioned earlier. So when there are ruptures along the MTJ, the edema pattern creates a feather-like pattern on the images. So just to summarize, muscles that cross two joints and have a pennant shape accompany large tendons and thus large MTJ area, which means there is a large amount of area within that muscle that undergoes very high tension, especially during max eccentric contractions. Also, muscles that have a high type 2 fiber type distribution is also highly susceptible to a strain because type 2 fibers, when contracting, develop not only high amounts of tension, but develop tension at a very high rate. Couple that with an external pulling or counterforce, this can increase the risk for a tear or rupture.